Good afternoon, everyone. We're going to go ahead and get started. Welcome to the 2017-2018 Annual Influenza Season Kickoff webinar. My name is Shannon McBee. I'm the Influenza Coordinator with the West Virginia Bureau for Public Health. I'm going to be starting off today's webinar. I'm going to start off with some housekeeping reminders. If you are viewing the webinar using your computer on Microsoft Live Meeting, make sure that your volume on your computer is turned up so that you don't have to call into the conference call. If you are listening via conference call, please mute your line. This webinar is being recorded and will be available after the webinar on our website. And then at the end of the complete webinar, we are going to have a question and answer session. So the objectives of today's webinar is to describe the components of the influenza surveillance program and the importance of influenza surveillance. We're going to summarize the 2016-2017 influenza season, review the roles and responsibilities of the local health departments, influenza sentinel providers for the upcoming flu season. We're going to discuss the key aspects of investigating influenza outbreaks. We will summarize the recommendations for the 2017-2018 influenza vaccine. We'll review respiratory specimen testing. Then Ariana DeBar, our vaccine preventable disease nurse, will be joining our conference call, and she's going to summarize the reporting requirements for acute flaccid mellitus, and she's also going to take the time to describe a varicella surveillance project for school nurses. Slide 3. So I'm going to start off today by describing influenza surveillance in the United States. The data that I'm about to show you can be accessed through our website, and we link to the FluView website from CDC. Slide 4, CDC receives influenza test results from public health and clinical laboratories located in all 50 states. During the 2016-2017 flu season, 70% tested positive for influenza A viruses, and 30% tested positive for influenza B viruses. Nationally, the percentage of specimens tested by clinical laboratories that were positive for influenza peaked during the week ending February 18, 2017. Public health laboratories tested a total of 84,000 specimens during the 2016-2017 season. Of the specimen subtypes, nearly 98% were influenza A H3N2 and 2.8% were influenza A H1N1. Of those specimens testing positive for influenza B, 71% belonged to the Yamagata lineage, and nearly 29% belong to the Victoria lineage. There were 3 human infections with novel influenza A viruses also reported during the 2016-2017 flu season. The first was an infection with influenza A H1N1 variant virus reported by the Iowa Public Health. This patient was not hospitalized and fully recovered. The second case was a human infection with a North American lineage avian influenza H7N2. The patient reported close, prolonged, unprotected contact to respiratory secretions of an infected sick cat at the New York City Animal Shelter. This was the first avian influenza A H7N2 virus infection in humans detected in the United States since 2003, and the first known human infection with an influenza A virus acquired through exposure to a sick cat. The patient was mildly ill, not hospitalized, and fully recovered. The third and last case was an infection with influenza A H3N2 variant virus reported by the Texas Department of Health. This patient reported contact with swine at an agricultural event the week preceding illness onset. This patient was not hospitalized and fully recovered. Slide 6. Nationally, the weekly percentage of outpatient visits for influenza-like illness to healthcare providers participating in the U.S. outpatient influenza-like illness surveillance network was at or above national baseline of 2.2% from the week ending December 17 and remained at or above baseline for 17 consecutive weeks. Nationally, the peak percentage of outpatient visits for influenza-like illness was at 5.1% and occurred during the week ending February 11th. On average, the percentage of outpatient visits for influenza-like illness remained at or above baseline for 13 weeks. Slide 7. CDC monitors pediatric influenza deaths through the Influenza-Associated Pediatric Mortality Surveillance System. A total of 105 laboratory-confirmed pediatric deaths were reported during the 2016-2017 season. Influenza-associated pediatric mortality became a nationally notifiable condition in 2004. The total number of influenza-associated pediatric deaths per season has ranged from 37 to 171. This is excluding the 2009 pandemic, in which 358 pediatric deaths were reported. Slide 8. CDC monitors hospitalizations associated with laboratory-confirmed influenza infections in adults and children through the Influenza Hospitalization Surveillance Network. The hospitalization rate was highest among persons aged 65 years of age and older, and accounted for approximately 50% of the influenza-associated hospitalizations. Medical chart abstraction data revealed that 94% had at least one reported underlying medical condition that placed them at high risk for influenza-associated complications. The most common underlying medical condition included cardiovascular disease, metabolic disorders, obesity, and chronic lung disease. On an interesting note, among the 447 women of childbearing age, 15 to 44 years of age, that were hospitalized with laboratory-confirmed influenza, nearly 30% were pregnant. Next, we will look at influenza surveillance in West Virginia. Let's first off describe the reporting requirements regarding influenza. Influenza is a nationally notifiable condition and is a notifiable condition in West Virginia from the reportable disease rule. For laboratories, influenza is a Category 5 disease. Positive influenza laboratory results by culture or PCR are required to be reported within 1 week to the state health department. This is important for hospital laboratories to know. For healthcare providers and facilities, influenza is a Category 4 disease. Influenza deaths in an individual less than 18 years of age are reportable within 1 week to the local health department. Influenza outbreaks are immediately reportable to the local health department. Slide 11. West Virginia collects influenza test results from hospitals and referral laboratories. During the 2016-2017 flu season, the percentage of specimens tested positive by hospitals and referral laboratories that were positive for influenza peaked during the week ending February 18th, similar to what we saw nationally. Slide 12. The Office of Laboratory Services is our state public health laboratory and a World Health Organization collaborating laboratory. They test all respiratory specimens submitted by sentinel providers and hospitals for influenza. They subtype all specimens, which determine what types of viruses are circulating and detect novel viruses that are indistinguishable by other laboratories. The predominant strain that circulated during the 2016-2017 season in West Virginia was Influenza A H3N2, followed by Influenza B of the Yamagata lineage that we saw in early spring this year. Slide 13. Outpatient surveillance is conducted through the Influenza Sentinel Provider Program. This data represents the percentage of individuals going to a physician with influenza-like illness reported by West Virginia providers. West Virginia providers reported those seeking care for flu-like symptoms was at or above baseline from January 1st, 2017 through April 1st, 2017, or 13 consecutive weeks, which is comparable to what we saw nationally. Syndromic surveillance uses information on emergency department visits and hospitalizations from hospitals across West Virginia to track health-related data for public health uses. The platform West Virginia uses is called Essence, which enrolled hospitals report chief complaints and final diagnosis data for influenza-like illness as a proportion of total patients seen. Syndromic surveillance allows us to determine the start and the end of flu season and when the flu season peaks. The graph on page 14 shows the temporal trend of influenza season for the past 4 flu seasons. The 2016-2017 season is shown in purple. Slide 15. Outbreaks are immediately reportable to the local health department. Influenza outbreaks are investigated and managed by local health department staff in order to reduce the morbidity and mortality associated with influenza. A total of 79 influenza outbreaks were reported during the 2016-2017 season. West Virginia typically sees more flu outbreaks during H3 seasons, as we did last season, compared to the 38 outbreaks that we saw during the 2015-2016 season, where H1N1 predominated. Slide 16. Of the 79 influenza outbreaks reported, over 65% occurred in long-term care facilities, followed by schools and daycares at 25%. Slide 17. Outbreak reports are required to be submitted by the local health department to the state health department within 30 days of closing the outbreak. Of the long-term care facility outbreaks reported, we received reports from 90% of the outbreaks. The following bar graph shows you the predominant symptoms reported by long-term care facilities. Slide 18. Nearly all the flu outbreaks reported had some type of laboratory testing completed. Unfortunately, only a quarter of the outbreaks were confirmed by PCR. During the current season, we're really going to push for confirmatory laboratory testing. This will reduce unnecessary treatment with antivirals among residents and will allow us to determine what type of subtypes of influenza is currently circulating across the state. Laboratory testing for influenza outbreaks is free of charge. If specimens are negative for influenza, they are reflexed to the BioFire film array, which tests for 21 different respiratory pathogens. Slide 19. Of the long-term care facility outbreaks that we received a report on, 60% of the facilities reported having standing orders for the administration of antivirals such as Tamiflu during flu outbreaks. Nearly 90% reported offering flu vaccine annually to their staff and residents. Almost 90% of local health departments reported using a conference call as a method to manage flu outbreaks in long-term care facilities, and only 20% reported conducting an actual site visit. Lastly, 30% of local health departments reported that they are utilizing daily reports from facilities as a method for managing influenza outbreaks in long-term care facilities. The role of local health departments is to recruit and maintain a sentinel provider. This is a grant requirement for federal threat preparedness funds. Local health departments are required to report all outbreaks within 60 minutes to the Division of Infectious Disease Epidemiology. Additionally, all influenza-associated pediatric deaths are reportable to the state health department. We investigate these at the state, so I ask that any suspected cases be reported as soon as possible, although you do have 1 week to report them officially to the state. Lastly, it's the local health department's role to investigate and manage all reported influenza outbreaks. In order to help you do this, I ask that you maintain a supply of viral transport media year-round at your health department. Slide 21. An influenza sentinel provider is a healthcare provider that conducts surveillance for influenza-like illness in collaboration through the state health department and the Centers for Disease Control and Prevention. Each provider collects the total number of patients seen weekly and the total number of patients seen weekly for influenza-like illness, and they report this information to an online surveillance database called the ILI-Net. Providers should report to the online system at least 17 of the 33 weeks from the beginning of October through the end of May. A sentinel provider can be a provider of any specialty or in any type of practice. Hospitals participating in the syndromic surveillance program called Essence are no longer allowed to participate because we receive their data electronically. Hospitals are encouraged to continue to submit respiratory specimens to the state lab for surveillance purposes free of charge. Data collected from influenza surveillance providers provides a picture of influenza activity across West Virginia and is an important aspect of statewide surveillance efforts for influenza and other respiratory pathogens. The influenza activity reported helps us determine the start, the peak, and the end of flu season, as well as an indication of the severity of the flu season. For those who have submitted enrollment packet forms to us, packets will be mailed out prior to the beginning of the flu season, which officially starts October 1st. Included in this information will be forms about ordering flu kits and how to access the ILI-Net system. For those providers who had vaccine requests, those will be processed on September 20th, tomorrow, and providers should receive an email later this week about their vaccine shipments. Slide 22. Hospital laboratories are required to report weekly aggregate influenza totals to the state by type and subtype as available. Slide 22 shows a copy of the reporting form hospitals may use to report weekly to the state. A copy of this form is located on our website, or you may email me and I would be happy to send you one. Results should be reported weekly for the previous week's data from Sunday to Saturday by Tuesday for the previous week. Slide 23. Routine annual influenza vaccination is recommended for all persons aged 6 months of age and older who do not have contradictions. Children aged 6 months through 8 years of age are required to have 2 doses of influenza vaccine during their first season of vaccination. Their first dose should be administered as soon as vaccine becomes available, and the second dose should be administered at least 4 weeks apart. While there are many different types of flu viruses, a seasonal flu vaccine is designed to protect against the top 3 or 4 flu viruses that research indicates will cause the most illness during the flu season. It takes about 2 weeks after vaccination for antibodies to develop in the body and provide protection against the flu. Live attenuated influenza vaccine, or the flu mist, is not recommended for use for this season because of its effectiveness. Influenza vaccination is the single best way to protect yourself against flu. It is recommended that everyone receives their flu vaccine by the end of October if possible. Slide 24 shows the vaccine composition for the 2017-2018 flu season. The vaccine composition has been updated this year to reflect changes in the predicted circulating viruses for the upcoming season. In particular, there was a change in the Influenza A H1N1 component from the previous season. Slide 25. Submitting respiratory specimens for surveillance purposes is highly recommended. Hospitals and influenza sentinel providers can submit up to 5 specimens per week to the state lab. Providers should collect specimens on symptomatic patients who have a fever of greater than 100 degrees Fahrenheit with a cough and/or sore throat. Flu kits can be ordered by submitting a requisition form to the Office of Laboratory Services. Flu kits are free of charge. Each local health department should maintain a supply of flu kits year-round to respond to respiratory outbreaks. We would like to encourage providers and hospitals to submit both screened and unscreened respiratory specimens. This means if the patient has had a rapid test or another influenza test, the specimen is considered screened. All respiratory surveillance specimens will be tested at the state lab for influenza. Additionally, any specimen that is negative for influenza will be tested on the film array for 20 different respiratory pathogens. Providers and laboratories may batch shipments of specimens. If specimens cannot be shipped within 24 hours of collection, you may freeze the specimens. Lastly, we do not recommend that you ship on Thursdays unless you are close to Charleston. Our laboratory is not open on the weekend unless prior arrangements have been made for outbreak response. Slide 26. In recent years, various forms of mandatory enforcement policies have been implemented in healthcare settings to increase influenza immunization of healthcare workers. More than half of U.S. hospitals have implemented requirements for influenza vaccination of hospital healthcare workers. Vaccination of healthcare workers is associated with reduced mortality in chronic care and long-term care facilities and reduced hospital-acquired infections in acute care. The literature supports that influenza vaccination can reduce absenteeism due to influenza-related illnesses. Many hospitals have reported requiring face masks for healthcare workers who do not receive their annual influenza vaccine. Low vaccination rates among healthcare workers could get the flu and then pass it on to coworkers or patients. People with the flu are contagious for up to 1 day before symptoms appear, and they can spread the virus without even realizing it. Patients in healthcare facilities are especially vulnerable to influenza. Young children, pregnant women, and the elderly, and those with chronic conditions are at greater risk for flu-related hospitalization and death. Slide 27. Outbreaks in long-term care facilities are a significant public health interest because of the increase in mortality and morbidity associated with influenza in the elderly. Case ascertainment of elderly residents with respiratory illness can be challenging. Using the McGear's criteria can be very helpful in determining whether you are dealing with an influenza, a pneumonia, or a lower respiratory outbreak. When defining cases of influenza-like illness in the elderly, it is suggested that you use the McGear's criteria. This includes an individual having a fever greater than 100 degrees Fahrenheit. They also must have 3 sub-criteria symptoms, which include chills, a new headache or eye pain, malaise, body aches, loss of appetite, sore throat, or a new or increased dry cough. The McGear's Case Classification Worksheet for respiratory illnesses in long-term care facilities can be found on our website, located under the local health department icon under the long-term care facility outbreak toolkit. Once an outbreak has been identified, prevention and control measures should be implemented immediately to prevent further transmission. Standard and droplet precautions are recommended for all residents with suspected or confirmed influenza for 7 days after illness onset or until 24 hours after the resolution of fever and respiratory symptoms, whichever is longer. All residents who are symptomatic should receive antiviral treatments. Treatment should not wait for laboratory confirmation. Antiviral prophylaxis is recommended for all non-ill residents regardless of vaccination status. This can be very difficult in a large facility because of the cost. In instances where symptomatic residents are isolated to a single wing or a hall, it is acceptable to administer post-exposure prophylaxis to just the affected wing or hall as long as there is no further transmission outside. This is why cohorting staff is often crucial to preventing further transmission in this type of setting. Additional information and recommendations on managing flu outbreaks in long-term care facilities or healthy populations can be found on our website in our toolkit for long-term care facilities. Below is my contact information on slide 28. Next, I would like to introduce to you Ariana Jabbar, our vaccine preventable disease nurse.
Hey y'all, I am Ariana. I'm the vaccine preventable disease nurse like Shannon said. This afternoon I'm going to do a brief overview on enhanced varicella surveillance for schools and school nurses that we are hoping to start up here soon, and also a brief overview of acute flaccid myelitis. Our objectives are for to gain understanding on what enhanced varicella surveillance is and its benefits, gain understanding on who the key players are for enhanced varicella surveillance and what their roles are. Per the West Virginia Reportable Disease Rule, outbreaks of varicella are to be reported to the local health department immediately, and an aggregate number of varicella cases should be reported weekly. I'm going to discuss with you all the differences between the varicella aggregate reporting and enhanced varicella surveillance. So for the why it's required for varicella, the aggregate reporting is because it's under the West Virginia Reportable Disease Rule. For enhanced varicella surveillance, it is a grant requirement under the ELC grant. The target population for the aggregate reporting is healthcare providers, school nurses, and healthcare facilities. For the enhanced varicella surveillance, it's all students K through 12 in West Virginia public schools. For the aggregate reporting, the local health department nurses collect the data, and for enhanced varicella surveillance, the school nurses collect the data. For both aggregate and enhanced surveillance, the reporting is weekly. The data is submitted through West Virginia EDS for varicella aggregate reporting and through a SurveyMonkey and an Excel spreadsheet for the enhanced varicella surveillance. For the frequency of reporting, it's weekly, every Monday for the previous week's count for the aggregate reporting, and for the enhanced reporting, it's weekly to the local health department and then monthly to me within DIDE. Number of reports submitted for the varicella aggregate reporting will be 1 report per the county, And then for the enhanced varicella surveillance, it will be 1 report per school. So it will be multiple within a county. The outcome of enhanced varicella surveillance in West Virginia public schools will aid in improving varicella outbreak detection, ensure prompt interventions, and ensure proper and timely reporting of varicella outbreaks. It will also assist in assessing the effectiveness of 1 versus 2 doses of varicella vaccine. So that was very quick. So the next topic I'm going to talk about is acute flaccid myelitis, or AFM, and its reporting requirements. So I'm now on slide 35. The objectives are for you all to obtain knowledge on acute flaccid myelitis and to learn its reporting requirements. Slide 36. AFM is a syndrome characterized by sudden onset of weakness in 1 or more limbs and distinct abnormalities of spinal cord gray matter on an MRI. Suspect cases of AFM should be reported within 1 week to the local health department. Slide 37. Symptoms of AFM include sudden onset of limb weakness, loss of muscle tone and reflexes, facial drooping, facial weakness, difficulty moving their eyes, drooping of eyelids, difficulty swallowing, slurred speech, numbness, and tingling of limbs. Next slide. There is not a known etiologic agent for AFM. It can be caused by enteroviruses, polio and non-polio, mosquito-borne diseases such as West Nile, Japanese encephalitis, and St. Louis encephalitis, or adenoviruses. Slide 39. The incubation period, communicability, and mode of transmission depends on the etiologic agent. There's no specific treatment for AFM. If an individual has AFM, their treatment would be based upon the symptoms that they are presenting with. Slide 40. Although the etiology of AFM is uncertain, there are some interventions that are a good way to try and prevent AFM. They are to ensure up-to-date vaccinations on all recommended vaccinations, particularly the poliovirus, minimize risk of mosquito-borne illnesses by using repellent when in high-risk areas, and eliminate stagnant and standing water near housing, and washing your hands frequently because washing your hands helps stop the spread of infections. Slide 41. Regardless of laboratory results, all case patients who meet the clinical case definition of AFM as soon as suspected should be reported to the local health department. Cases should be reported within 1 week. You will report using the AFM patient summary form that is provided by CDC, and a link for this form can be found on our DIDE protocol. This form should be completed by or in conjunction with a clinician who provided care to the patient during the neurological illness. The completed form is to be submitted to the state or local health department. Healthcare providers also need to assure that the proper specimens are collected as soon as possible in the course of the illness. Slide 42. Preferably, specimens should be collected within the same day as onset of limb weakness. Specimens collected early in the illness have the best chance of yielding a diagnosis. Specimens that need to be collected for testing of AFM are 2 milliliters of unspun and 1 milliliter of spun CSF. Serum will be spun in a tiger top tube. After the serum is spun, it should be poured into a standard cryovial tube. The unspun whole blood needs to be collected in a lavender top tube with an anticoagulant. 2 stool samples should be collected 24 hours apart, and also 2 rectal swabs should be collected 24 hours apart. The specimens I have listed are required. There are some that are also optional, which are an NP and OP swab, fresh frozen tissue, or paraffin-embedded tissue. Also, there should be an MRI that needs to be completed to assess the spinal cord gray matter. Slide 43. Prior to the occurrence of AFM, providers should be educated. This is local health responsibilities, I'm sorry. So prior to the occurrence of AFM, providers need to be educated about AFM and how to detect it. Healthcare providers also need to know the reporting requirements of AFM. When educating providers, be sure that they know what specimens they would need to collect so they can have the proper supplies available. Some more local health department responsibilities. When a suspected AFM case is reported, the patient summary form needs to be completed. And like I said before, this should be completed by the healthcare provider, preferably providing or managing the care for the neurologic condition. You also need to obtain medical records that are related to the AFM, report the suspected AFM to the epidemiologist on call, and be sure to follow up with the provider and collect the completed patient summary form and submit all this information to DIDE. Slide 45. Make sure you do not wait for the lab results prior to submitting the paperwork. Lab results can be added and or updated as needed. And also, if there's 10 or more specimens that are going to be submitted, a line list needs to be created and sent via email. Slide 46. Our responsibilities here within DIDE is to educate local health departments, provide situational awareness to stakeholders via health alerts, educate healthcare providers, assist with investigations, submit completed patient summary forms to CDC, and update AFM information as needed. We also develop the health alerts and summarize surveillance data. Slide 47. AFM is of public health significance because it primarily affects children but has been reported in adults. There is not a specific causative agent and not much is known for AFM. It can be confused with other disease entities, and there is no vaccine that protects against AFM. Just some surveillance information is in 2014, there was 120 confirmed cases. In 2015, 21 confirmed cases. And in 2016, there were 138 cases amongst 37 states. And that's all that I have. Here's my contact information. Feel free to email me with any questions. And also for more information, you can visit our DIDE website at www.dide.wv.gov.
At this time, we are going to unmute the conference call lines so that people can ask questions. And you can also submit questions for Ariana or myself by clicking on the question and answer tab at the top of your screen and typing your question and then clicking ask.
All guests have been unmuted. You will now rejoin the meeting.
All right, I've unmuted everyone's line, so be careful of your P's and Q's. Does anyone have any questions? Okay, well, it looks like some folks had some technical difficulties, so we are recording the webinar and we will be sending this out via email, and we'll also post it on our website as soon as possible. Last call for questions regarding the influenza season, sentinel providers, AFM, varicella reporting. All right. Well, thank you guys so much for joining us. You guys have a great afternoon.